Hi, everyone. Welcome to Texas Fertility Center's Male Infertility webinar. My name is Brandy Thomas, and I'm the producer for Texas Fertility Center. I've also got Dr. Silverberg on here. He's a little, I don't know if you guys can see him, but he's down there minimized, and I'll bring him on in just a minute to cover all these great things we're going to be talking about today. Before I do, I wanted to go over a few things regarding this webinar. Dr. Silverberg is going to stop to answer questions, which you can see on the right-hand side. There's a little question tab, and you could submit your questions there. All questions are private. No one else will see your questions. You don't have to worry about that, and they will be answered anonymously. So he's going to stop in the middle of the webinar as well as at the end to answer those. So be sure to take advantage of that. In addition, this is something that we do on a monthly basis. We cover everything ranging from Fertility 101. We're doing one on PCOS, lots of different things coming up over the next year. So be sure to visit our website at txfertility.com, and you will find tons of information on that. I think that about covers it for now, though, so I'm going to go ahead and bring on Dr. Kaylen Silverberg.
Hi, Brandy. Thanks so much for doing this. We sure appreciate it. I'd like to welcome everybody tonight. You're in my home office, which I would actually love to give you a tour of, except for the fact that it's a pit at the moment and there's just junk everywhere. But anyway, I'm going to talk tonight about male factor infertility. It's an interesting topic to me. Hopefully it's an interesting topic to you as well. We sure appreciate you guys logging on. I don't know if we're going to fill up the whole hour tonight, but we'll go. And I'd love to take questions. So any questions that you have, we will make sure that we cover. So the first thing is really just to talk about why is male factor infertility important, and why are we as gynecologists even focusing on male factor infertility? Just to give you some background, we are reproductive endocrinologists. So every physician at Texas Fertility Center is a board-certified reproductive endocrinologist. There's 7 of us. We have 5 in Austin. We have 1 in New Braunfels who also covers our Corpus Christi office. And then we have 1 physician in San Antonio who covers that office as well. To do reproductive endocrinology, you do not only 4 years of college, but 4 years of medical school, then 4 years of an OBGYN residency. And then it used to be, when Dr. Vaughn and I went through and Dr. Hansford went through, it was a 2-year fellowship in infertility. Now it's a 3-year fellowship in infertility. So people who've come after us have had an additional year of training. And then you have to take both sets of board examinations. So you have to be board certified in obstetrics and gynecology first, and then you can get board certified also in reproductive endocrinology and infertility. So all of our physicians at TFC are doubly boarded in both OB-GYN and in reproductive endocrinology. The interesting thing is that we have no urologic training, and urologists, who are the male factor doctors, the male doctors, were really late arriving to this party. So when we were involved in this at the very beginning, we had to do everything. We had to do the male issues, we had to do the female issues. Much more recently, there are a few fellowships now that train physicians, mainly urologists, in male infertility as well. But they are learning the same things that we've learned all along. So this is really why we focus on couples, because we know that about half of the cases of infertility are due almost solely to male factors, and about half the cases to female factors. So you really can't if you just look at women and do the basic evaluation that we've talked about before. We evaluate ovulation, we evaluate the fallopian tubes, we evaluate the uterus, we make sure there's no endometriosis. We do the basic things for female factor infertility, egg quality, those kind of things. If you do that, you're really leaving out half of the problem, half of the issue. So the other half of the issue is what I'd really like to focus on tonight. So male factor infertility, as I said before, comprises somewhere between 40 and 50% of all cases of couples seeking care because they can't conceive. How do we do a male factor evaluation? Well, we really do it basically initially the same way we do a female factor evaluation. And that is, we sit down and we take a medical history. So we'll talk to the guys about previous medical illnesses, previous operations, any sexually transmitted diseases. And let me go through that a little bit more in detail. So when we're sitting down, we're asking them about any illnesses, for example. So high blood pressure, for example, is treated with certain types of medications. And those high blood pressure medications can interfere with sperm production, and they can also interfere sometimes with sperm function. So when we have guys who are taking antihypertensives, they may very well have a decreased libido. They may very well, in some cases, have retrograde or backward ejaculation. We'll talk about that a little later. And so it's important to know about these things and about these issues. Say, for example, that guys have issues with depression or with anxiety. They may be on serotonin reuptake inhibitors, SSRIs. And we know that SSRIs can interfere with libido. And we know that SSRIs can also interfere sometimes with the ability to ejaculate. Guys who have benign prostatic hypertrophy, they've got enlarged prostates, they're frequently taking medications that can also interfere with ejaculation. A lot of the medicines given for benign prostatic hypertrophy, for example, not only can they decrease libido, but they can also cause retrograde ejaculation. And what that means is that instead of ejaculating the sperm forward and out through the penis, when a man ejaculates, the sperm go backward and they go into the bladder. And that's a significant issue, significant problem. Easy to treat. All of these things really are pretty simple to treat. You just have to make a correct diagnosis. We'll then talk about surgical issues, or I'm sorry, back on medical issues. What if a guy had cancer? For example, Hodgkin's disease when he was younger, testicular cancer when he was younger. They may have removed one testicle, maybe irradiated the other testicle, or he may have had lots of radiation or chemotherapy with other types of cancer. We know that that can adversely affect sperm production as well, even later in life. Fortunately, it appears that with a lot of childhood cancers, early treatment may disable or significantly impair sperm production at that point in time. But later on in life, these guys frequently recover their sperm production and can go on to father kiddos without much trouble, much difficulty. So we really want to go through a thorough medical history. We'll also go through a thorough surgical history. So have guys had, for example, operations on their scrotum, hernia operations, vasectomies, obviously, vasectomy reversals, obviously. Any kind of scrotal surgery or surgery near the scrotum can affect sperm production. And it can also affect sperm delivery. So it's very important that we evaluate these things and we find out about these things. We'll talk a little bit more about varicoceles later, but varicocele surgery is also very important. So after we do the medical history and we do the surgical history, we're going to talk to them about their sexual history. So for example, have they had sexually transmitted disease? Because that's very important and that can impact future fertility as well. We'll talk to them about medications that they're on for all the reasons that I've discussed already, because we know that a lot of these medications can impact sperm production. Some can impact sperm delivery as well. We'll talk to them about cigarette smoking. We know that that's an issue. Alcohol can interfere significantly with not only sex drive and sexual performance, but it can also affect testosterone metabolism and testosterone production, and that can also adversely affect sperm production as well. We'll talk to them about medications that they're on. I've taken care of my career. I've taken care of a lot of guys who are bodybuilders, very interested in their physique, very interested in sculpturing these muscles, but unfortunately they're taking androgens or androgenic products, testosterone-like products, to help them achieve better results in the gym. And it's great that they achieve better results in the gym, but unfortunately, when a guy takes testosterone, it's very similar to a woman taking a birth control pill. So when a woman takes a birth control pill, which has a lot of estrogen in it, what happens is the brain picks up on the fact that there's a lot of estrogen circulating. And the brain then tells the pituitary gland, a little pea-sized gland that lives behind your nose, you know what, we don't need a lot of estrogen production now. So we don't need egg development because there's lots of estrogen circulating in the system. So the brain essentially tells the pituitary gland to stop stimulating the ovaries. Women stop making eggs. And that's why about 90% of women who take birth control pills don't ovulate. Well, the same thing can happen with testosterone in guys. So when a man is taking a testosterone product or a testosterone derivative to help him bulk up, what's happening is the brain senses that there's a lot of testosterone around. The brain sends an altered signal to the pituitary gland to say, hey, you know what? You don't need to bother to stimulate the testicles to produce testosterone or to produce sperm. And so what can happen is a man's endogenous or testosterone that he makes on his own, his endogenous testosterone levels can go down. When that happens, his sperm production may very well go down as well. So I've taken care of a lot of guys, these bodybuilders, who come in and they've got very, very low sperm counts. Some of them also have difficulties getting or maintaining an erection. Some of them also have difficulties with ejaculation. So it's important to evaluate these things and to talk about them, both sexual history and medications that guys can be on as well. Again, cigarettes we've discussed, alcohol we've discussed. We'll talk about family history. Do they have a history of male infertility in their families? Could there be some genetic issue that's going on as well? We talk about other genetic illnesses, like, for example, cystic fibrosis. So we know that cystic fibrosis can be associated with a condition called congenital bilateral absence of the vas deferens. So what can happen in guys with cystic fibrosis is they may be born without the tubule that's necessary to carry sperm from the testicles to the outside. And when that happens, that's a significant issue, significant problem. Again, treatable, but a significant issue. And so, like I said, we start off with the history, which is very, very important to find out as much as we can about these guys. Have they fathered children in the past? If they fathered children in the past, when was the last time they fathered a child? What has happened in that intervening period of time? We'll also talk about habits. Do they exercise? Do they ride bicycles? Are they working outside? Do they work in the heat in Texas in 100 and 110 degrees? That can significantly affect sperm production. Much more of an issue in Texas, for example, than somewhere in the Northeast or the Northwest, where the temperature doesn't get to be so high. So meanwhile, during this evaluation, after we do the history, we typically don't do physical examinations. If we're worried about a guy and we're worried about very low sperm production and sperm function, we will send him to one of a few urologists in town who really do have an interest in male fertility. And so we work with several of the leading urologists in Austin to help us on the male factor side. They will typically do an evaluation of the man as well, do a physical examination, and then they'll make sure that there's no mass in the testicles, there's no abnormality in the scrotum, nothing like a dilated group of veins called a varicocele or a spermatocele or a hydrocele, or things that can, again, interfere with delivery of sperm. And once we know for sure that there are no abnormalities there, they will then help us as we do a hormonal evaluation of these guys. And we'll get into a little bit more of this in just a minute. So how do we evaluate these guys? After we've done the history, after we've had a urologist do the physical, we'll do a semen analysis. That's the standard part of the male factor evaluation. There is a lot of variability in semen analyses. And in fact, I write the chapter on sperm handling and sperm production for David Gardner's textbook on in vitro fertilization. So if you really want to read something at night that'll give you a lot of information and also help you sleep like a baby, I'm happy to make that chapter available to you. You're welcome to look at it, welcome to read it. But it really does go in a lot of depth. I wrote it with Tom Turner, who used to be our chief embryologist before he retired. And we've written, I think, a really comprehensive chapter on sperm production, sperm function, and even getting sperm ready for in vitro fertilization. But anyway, so when you look at the data and you look at semen analysis is the classic test that's been performed to evaluate male fertility. The problem is we have, even to this day, a lot of difficulty using just a semen analysis to distinguish between a guy who's fertile and a guy who's not fertile. So to give you an example, if I told you the way that these semen analyses normal ranges were initially established, you wouldn't believe it. So here goes. In the original studies, what they actually did was they went to OB clinics and they identified men who accompanied pregnant women to these visits. They assumed that these guys were the fathers of the baby. They got them to produce a sperm specimen. And then when they did these semen analyses and got these sperm specimens, they looked at them, and using those, they were able to build 95% confidence intervals around this to determine or to be able to distinguish between normal semen analyses from guys who they thought had fathered pregnancies and guys who went to fertility clinics who may or may not have been infertile. And so it was really a very poor way of determining what the normal ranges were for semen analysis. In addition, they really only looked, they almost all exclusively looked at Caucasians. They almost exclusively looked at people in Northern Europe and in the United States. So you had sampling errors because, as we know from pretty much everything else, there are differences in people around the world. So a normal semen analysis in England may not be the same as a normal semen analysis in the Middle East or in Africa or even in Asia. Same thing with the United States. So subsequent studies were done broadening the quality of the men that they looked at, broadening the ethnicity, broadening the age range as well. And I think that now we're more honed in on what a normal semen analysis really looks like. So what we use at Texas Fertility Center, we use a sperm concentration. So in other words, how many sperm are there per cc of semen? So it's not just a sperm count. We all talk about sperm count, but it's really not a count. It's really a concentration, which is a number of sperm divided by the volume of the semen. So we can have guys who have relatively low sperm counts or sperm concentrations. They may only have maybe 10 million sperm per cc, with normal being 20 or better, but yet they may have 6 or 7 cc's of volume of semen with an ejaculate. And so once you do the math, you can figure out that they actually have more than the 10 million moving sperm that we like to work with. Same thing with motility. Motility is the percent of sperm that are alive and swimming. So when we assess a guy's semen analysis or a guy's semen, we will look first at the concentration, then we will look under a microscope and we will count out of every 100 sperm that we count, how many are actually moving. And we look at that and we categorize that as motility. Now, some people carry this out to the nth degree. I mean, CPL, if you do a semen analysis with CPL in Austin, they will look at your motility typically when they get the specimen, or what they call time 1 hour. Then they may look at it at 4 hours, and they may look at it even 7 hours later. I'm not aware of any literature that talks about the fact that that makes any sense. So again, we value CPL. They're a great partner for us for all the endocrinology that we do. But on the other hand, when it comes time for semen analysis, I really don't want to send you to a laboratory where they may have somebody who looks at sperm, once or twice a week. I want our embryologists and andrologists to evaluate your semen because they look at it all day, every single day of the year. So we don't do 4-hour and 7-hour assessments of sperm motility. We just do an immediate assessment of sperm motility, and then we move on from there. The third major characteristic we look at is normal morphology. So in other words, morphology means the shape of the sperm. So what is the normal shape of a sperm? You should have a single oval-shaped head, a single midpiece, and then a single tail. And so those are the 3 components of a normal sperm. And it's very important that sperm have normal morphology, because we know that the overwhelming majority of sperm, even normal shaped sperm, the overwhelming majority of sperm are chromosomally abnormal, and they typically don't work in nature. So we also know that when sperm have an abnormal shape, they are more likely to be chromosomally abnormal than sperm that have a normal shape. And that's very important because, for example, when we're doing ICSI, we are bypassing nature. And I'll talk a little bit more about ICSI in a little while. But when we do ICSI, the procedure where we pick up a single sperm with a microscopic needle and actually inject that sperm directly into the egg as part of an IVF procedure, we are bypassing nature. So my embryologists are doing the best they can. They're looking under the microscope. They're finding a sperm that has a normal shaped head. It's got a normal midpiece. It's got a normal appearing tail. It's swimming in a relatively straight line, relatively rapidly across the screen. And they assume, because this is really the state of the art in 2020, they assume that that sperm is normal, and they will pick that sperm up and use it for ICSI. But we know, unfortunately, that even the majority of normal appearing sperm are chromosomally abnormal. So if we pick up a sperm that's chromosomally abnormal and inject it into a normal egg, the second we do that injection, we have ruined, inadvertently, but still we have ruined that embryo. And that's very important to know, and we'll talk about that a little bit maybe later if you guys have questions about IVF and about ICSI. So we'll do the semen analysis, and the first thing you do if you get an abnormal semen analysis is not say, oh my gosh, this guy is infertile, he's never going to be able to father a pregnancy. The first thing we do is we say, hey, you know what? Let's repeat that semen analysis. And we ask a little bit more questions about it before we produce the specimen. So typically when we give a guy a form to get him to produce a semen analysis, we will ask him to abstain from any kind of ejaculation for between 2 and 5 days, 48 hours and 5 days. Okay, that's the interval that we would really like to achieve. We don't want him to go too long without ejaculating, because then the majority of the sperm in the ejaculate may very well be dead. We don't want him to have too little abstinence, because then the volume may be lower, and that can lead to abnormalities as well that are not real. So we would really like between 2 and 5 days of abstinence when a guy goes to get a sperm specimen. So what about the semen analysis? Let's talk a little bit about that. the semen analysis can be a really stressful thing for guys. I mean, as much as you think your partner may be into sex, he's more than likely into sex with you and not necessarily with a cup and a bag. And so we really try and minimize the stress that's involved in the production of a semen specimen. So we'll say to him, you know what, you're welcome. First of all, you don't have to collect the specimen in our office in kind of a sterile environment. You can collect the specimen at home. I tell my couples all the time that, you know what, your partner can help. Get her to help collect the sperm specimen. Anything other than intercourse and withdrawal is fair game. If need be, for religious reasons, for example, some guys need to use a collection condom. And so we have those that we can provide as well. But we want to do anything that we can do to make the semen analysis collection process not a big deal. Because, you know, guys who can perform without any problem at the drop of a hat, all of a sudden when you give them a cup and a bag and you say to them, hey, you know what, we've got to produce a sperm specimen and it's got to be right now, we can get a lot of issues. And this is why even with in vitro fertilization, sometimes we will offer guys, especially if they're the slightest bit concerned, we will offer them the opportunity to bank some sperm in advance, to go ahead and freeze some sperm specimens for us before the IVF case. So other issues, other things that we look at within a semen specimen, we look at volume, because certain conditions can impact volume of ejaculate. And we don't want too little volume, and we don't want too much volume as well. So all of those things are important. We also look for white cells, for the presence of white blood cells in a semen specimen, because we know that white blood cells can indicate either infection or they can indicate inflammation. And these are things that are, again, very easily treated. But if you've got a guy who's got a lot of white blood cells in his semen specimen, we need to really distinguish between those white cells and other types of what are called round cells. So what I mean by that is when you look under a microscope and you see a lot of round cells in the semen analysis, cells that don't have tails, cells that don't like sperm, that don't look like sperm, those could be white cells indicative of inflammation or infection, but they also could just be immature sperm. And so you have to do some very specialized staining. For example, I know CPL does not do this. We do this. Very few laboratories do this. We typically use something called horseradish peroxidase. It's an enzyme that we can use to treat the semen, and we use this to help distinguish between white blood cells and inflammatory cells or and immature sperm. So these are the things we look at when we look at a semen analysis. So it's not just a simple, hey, look, there's 30 million moving sperm. That's all great. We look at everything else in the process. Now, what other types of testing are there? Well, we sometimes look for anti-sperm antibodies. So what is an anti-sperm antibody? Well, guys can occasionally make antibodies to their own sperm. It's a relatively uncommon phenomenon because sperm are sequestered from our circulatory system by something called the blood-testis barrier. And so when that barrier gets violated, either because of an infection, inflammation, trauma, surgery, things like that, when that barrier gets violated, then sperm can leak from can leak into the circulatory system. And when that happens, those white blood cells that fight off infection in your body all day, every day, they're circulating around, they see a sperm and they say, what's that? The answer is, don't know. I've never seen it before. It must be a bacteria. Let's kill it. And so a guy can actually start making antibodies to his own sperm. That's easy to treat, but we have to be able to diagnose it. We don't typically test for anti-sperm antibodies except for in isolated circumstances. A guy who's had trauma before, scrotal surgery, previous infections, gonorrhea, chlamydia, things like that, then we'll look. And if we find antibodies, easy to get rid of. Then there's a lot of types of sperm function testing. And I think towards the end of the talk, if you remind me, we'll talk about DNA sperm fragmentation because this is one of the newer tests that's out there, pretty controversial, but we'll go through it. So let me see what time it's about 6:55. I think I'm going to take a few questions here. So let me go through because we're getting a ton of questions in. The first question, how common is male infertility? And like I said before, it affects about 40 to 50%, or it's responsible for 40 to 50% of all cases of infertility. The next one, are the negative effects of smoking and sperm production the same if it is tobacco or chew? And the answer is yes. So it's not inhaling the tar and the nicotine. It's actually just getting it into your system that can adversely affect sperm. So we really want to make sure for a variety of different reasons that guys stop smoking, stop dipping, stop chewing. What can a man do to improve the morphology and motility of his sperm? That's a great question. There's really not much that you can do to improve the morphology of your sperm unless an examination reveals something like a large varicocele. So a varicocele, I was going to talk about this a little later, but I'll talk about it now. A varicocele is a dilated group of veins that drains the testicles. So just to refresh your memory, you may not know this, arteries, which carry blood away from the heart, are thick-walled, and they've got to be thick-walled because when they come off the heart is contracting and beating and generating a huge amount of pressure to force that blood out of the heart to go around your entire body. The blood goes all the way out to your fingertips, to the top of your head, to the bottom of your toes, and then it turns around and comes back. So arteries take blood away from the heart. Then they go through the system of veins and capillaries, and then they go into veins, which brings the blood back to the heart. And that's very important when that happens, because as you get further and further and further away from the heart, I'm sorry, the emergency room is calling me here. 1 second. Okay. The further and further you get away from the heart, the lower the pressure head becomes. And so therefore veins, which are thin-walled, have valves that prevent the blood from going backward. So arteries don't need valves because you've got this pressure head coming off the heart, pushing the blood out through the arteries. But then when the blood is starting to come back, the pressure is markedly lower, and therefore blood can actually start to go backward. It's prevented from doing so by these valves. When these valves don't work well and blood can leak and go backward, you get what's called a varicose vein. And there's different types of locations of varicose veins and different names for varicose veins. When you have veins in your legs, those ugly spider kind of veins that show up, especially as you get older, what's happening is the valves in your veins are not working as well. Blood is flowing backward. And in your leg, that's called a varicose vein. If that happens around your rectum, that's called a hemorrhoid. Okay, very common. People don't know what hemorrhoids are. That's what they are. They're veins that drain the rectum that have valves that don't work very well, so that blood can go backward and it can form a little lump or a little mass. And then when the same thing happens in the scrotum, that's called a varicocele. So the veins that drain the testicles and bring blood back from the testicles back to the inferior vena cava and back to the heart, with those veins, if the valves in those veins don't work well, then blood can flow backward. And when blood flows backward, that's called a varicocele. A guy can feel it on examination. It almost always affects the left testicle more often than the right testicle, and that's just because of the anatomy. The right testicle vein, the right testicular veins drain directly into a very big blood vessel called the inferior vena cava, and that's the blood vessel that takes blood back to the heart. On the left side, the scrotal veins or the testicular veins drain into the left renal vein, which is the vein that drains the kidney, and then that takes it to the inferior vena cava. So there's more of a pressure gradient, and that's why these varicoceles almost always occur on the left side. So what happens? What's the problem? Well, pressure builds up in the testicle because of backflow of this blood. The blood doesn't drain appropriately, and when that pressure builds up, it also raises the temperature of that testicle, and we know that that's bad for sperm production. Okay, and also the pressure itself can adversely affect sperm morphology, the shape. So guys typically who've got big varicoceles will have a greater concentration of a specific morphologic abnormality in sperm called a tapered head. So if you look at it, the sperm head is usually oval shaped. But when you look at guys who've got a big varicocele, frequently they will have more what are called tapered sperm in their ejaculate, where the head of the sperm starts off at the bottom, it's kind of oval shaped, but then it comes really to a point at the other end, at the end of the head, and that's what we call a tapered shape. And sometimes that's a tip-off that a guy may very well have a varicocele. So anyway, that's the morphology of the sperm. What can we do to improve the morphology? Mainly find out if the guy's got a varicocele or not. And if he does, it may be worth fixing it. And again, we'll talk a little bit more about varicoceles. I've got a bias against fixing varicoceles unless they're symptomatic. So if a guy has got a large varicocele, if in fact the testicle on that side is actually starting to shrink because of the varicocele itself, or if a guy has got heaviness in that side of his scrotum or pain, those are reasons to go ahead and get a varicocele fixed. But it's not a reason if if you go to see a urologist and they say to you, you know what, you may have maybe a subclinical varicocele, maybe I feel a little dilated group of veins there. That's not reason to get your varicocele fixed, because there's a lot of data that shows that the fix of the varicocele may just be as bad as having the varicocele itself. In fact, you may not improve very much, and occasionally, things can happen in your sperm production or sperm count may actually go down. What about motility of sperm? A lot of different things can be done for motility of sperm. Mainly, they involve intrauterine insemination because it's just so easy. And we'll talk about IUI, IVF, and ICSI in a few minutes. Okay, let me see. Maybe I'll take one more question, and then we'll get back to what I was talking about before. If there's no apparent male infertility concern, is there any indication for ICSI, lack of PGS normal in past cycles? Oh, okay, I see what you're getting at. So this is a complicated question, a complicated answer. Most IVF programs in the country that do a lot of genetic testing require ICSI to be done prior to the genetic testing. Okay, and the reason is that when you incubate sperm with an egg with in vitro fertilization, typically we put about 15,000 moving sperm in a microscopic droplet of fluid surrounding each egg. And what happens is many sperm bind to the surface of that egg. One sperm gets engulfed into the egg, and that's the one that fertilizes the egg. But those other sperm are stuck to the outer membrane of the egg. And now you have a fertilized egg. It divides. It grows all the way to become a blastocyst. Now we're ready to biopsy that embryo, where we want to open up a hole in the membrane around the embryo. We want to tease out 3 to 5 cells from that 128 cell blastocyst. We want to then freeze those cells at 320 degrees below zero. And then we want to ship them off to our testing facility in Las Vegas. The problem is that when you drill that hole and you pull those cells out, if you don't do ICSI, you're going to have sperm that are stuck to that membrane. And if you pick up sperm, in fact, most of the data suggest at least 9 sperm. If you pick up at least 9 sperm with those cells from the embryo, DNA is amplified. The DNA from those sperm gets amplified as well. And that can lead to erroneous results with PGT. So we may very well all of a sudden see abnormalities in embryos that otherwise would have been normal. We avoid that by doing ICSI, because with ICSI, we can pick up a single sperm with a microscopic needle, we inject it into the egg itself, and then when we go to do the biopsy of the embryo, there are no sperm on the outside of that embryo. And when we remove those 3 to 5 cells, we don't have to worry about contaminating our specimen with extra sperm and extra sperm DNA. So the problem in this question, or this person is asking, lack of PGS normal embryos in past cycle, she's concerned because apparently when she's done IVF in the past, she has not gotten euploid blastocysts. She's gotten blastocysts with abnormal numbers of chromosomes. And she's wondering, I think what she's implying is, she is wondering if maybe, like I talked about before, when the embryologist picked up a single sperm with a microscopic needle and injected it, maybe they didn't do as good a job, not through their own fault, but maybe they picked up inadvertently chromosomally abnormal sperm and injected them. And that's certainly possible. What we are looking at in our IVF laboratory right now, this is a very timely question, is whether it is better when you have a guy who doesn't have male factor to just inseminate the eggs as opposed to injecting the eggs. And it may very well be, because as I said before, in nature, normal sperm tend to work and abnormal sperm tend not to work. So it may very well be that what we will find is with guys who don't have an abnormal semen analysis, that it makes more sense to just do insemination rather than ICSI. So hopefully that answers that question. How common is retrograde ejaculation? Fortunately, retrograde ejaculation is very uncommon. It is more common with diabetes, especially insulin-dependent diabetes. But otherwise, in the absence of taking certain medications that can cause retrograde ejaculation, it's uncommon. Next question. I did a semen analysis last year because my fiance and I had just turned 34. The one abnormality shown on the result was slight agglutination. What causes this? Okay, that could be a tip-off, usually not with slight agglutination, but agglutination means that the semen or the sperm are sticking together. And so that could be a tip-off that you might have anti-sperm antibody production. It's very important that you ask your doctor about that and whether they think that that's important, because they may want to send you off for an anti-sperm antibody test. And if you, in fact, are found to have antibodies, very easy to treat. It's just that when you ejaculate, instead of ejaculating into an empty cup, we will put a pink liquid in that cup that's got a specific type of protein, and we know that the antibodies bind to that protein preferentially. In other words, they will bind to that protein more often than they'll bind to the sperm, so they'll leave the sperm alone, they'll bind to that protein, and then when we're preparing the specimen for either IUI or for IVF, it's easy for us to isolate the sperm that are not antibody bound. Next question, how accurate are home semen analysis tests? I don't like home semen analysis tests. The reason I don't like them is because, as we say all the time when we're talking to guys about giving us a sperm specimen, we want to get that sperm within an hour of the time it's collected. And the reason we want to do so is we know that when you leave the sperm mixed in with the semen for longer than an hour after ejaculation, then that sperm starts to die off much more rapidly, and you're going to get a less accurate result. So with these home semen analysis tests, typically what you do is you collect a sperm specimen, you put it in some media, and then you actually ship the specimen off, and it goes to a lab in Boston, or it may go to Mayo Clinic. They've got a home test. There's a lot of different laboratories around the country that are offering and promoting their home tests. But the problem is you're not going to get the specimen for a day or two, and there's no guarantee that it's still, the motility, for example, is still going to be intact. And I'm aware of the data that these companies rely on to show that their tests are valid. I still just don't like it. I think that it's so inexpensive. I mean, a semen analysis is about $75. And, you know, if you do these home kits, they're probably $35, $40. And I think that it makes much more sense to get your semen evaluated by a professional with a fresh specimen rather than by shipping it off. Last question, then we're going to go back. So I completed my semen analysis and now on blood pressure medication. Can I have help in improving sperm quality, maintaining evacuation and delivery? So what I would do is, if you are on a blood pressure medication now that you weren't on before, then I would go ahead and I would make sure that your doctor knows that, and I would go ahead and get another semen analysis done. So we'll find out what it looks like now. We'll know what we're dealing with. And this leads me to another important issue. When we talk about sperm production, it's very important to understand that it takes between 90 and 108 days from the time a sperm is made until that sperm is ejaculated. So anything that happens in that 90 to 108 day period of time, if you get sick, if you get a fever, if you have an injury, anything that happens in that 90 to 108 day period of time is going to affect the sperm that are subsequently ejaculated. So this is another reason it's important, if you get an abnormal semen analysis, to repeat it, because we may be seeing something that happened 2-3 months earlier, and that may have corrected itself or may have been corrected in the intervening period of time. So now back to the things I was going to talk about. What are causes of male factor? Well, first of all, they're anatomic causes. So things like obstruction or varicoceles. We talked briefly about varicoceles already. I'll leave more of that discussion in case there are any questions about that. And then obstruction, there's things that can obstruct the vas deferens, which is the tube that carries sperm from the testicle to the outside. So for example, sometimes you can have a surgical misadventure. You go in for a hernia repair and the vas deferens goes along that side where the hernia sac might be. And sometimes in hernia repair, you can injure the vas deferens and cause an obstruction. Like I said before, you can have a genetic issue where you're born without a vas deferens. And that's very important. Other etiologies, infectious etiologies. So for example, we know that gonorrhea has a potentially significant adverse effect on sperm production. It appears that chlamydia may have some effect as well. We're not really sure about that yet. Endocrinologic is the next group of the next category. So when we have guys who have low sperm concentrations, one thing that we will do is we will get a hormone panel on them. So we'll check an FSH, we'll check an LH, we'll check a testosterone, and in fact, we may even check an estrogen level. And what we know, because we've published a lot on this, Dr. Vaughn and I have published a bunch of papers on this, what we know is that if a guy has got a low sperm count or a low sperm concentration, and he has a low FSH and a low testosterone level, then he may very well respond to Clomid. The same woman we give to women to make them ovulate regularly, we've given to guys, and we've given it to hundreds and hundreds of guys. And if they have a low FSH and a low testosterone, frequently they will respond with a significant improvement in their sperm production. The motility is typically not affected, and the morphology is typically not affected, but sperm concentration may significantly go up. And so that's very, very important. Now, endocrinologic factors can also point us in other directions. So just like women, women can go through menopause, and one of the markers for a woman going through menopause is an elevated follicle stimulating hormone level, an elevated FSH level. Remember, FSH in women stimulates eggs to develop. FSH in men stimulates sperm development. LH is also an important factor. So LH in women can cause production of androgens, which eventually become estrogens, and LH in men cause testosterone production. So it's important for us to know what your FSH level is, what your LH level is, and what your testosterone level is. And if your levels are low, like I said before, we'll make sure that the urologist says there's no mass, there's no problem from giving you Clomid, because Clomid occasionally can be bad for you if, for example, you have a testicular tumor that's undiagnosed. So that's going to be very important. But we would potentially put you on Clomid, markedly raise your FSH production, markedly raise your LH production, and that's going to markedly raise your testosterone production and hopefully raise your sperm production also. Now, it's a little more complicated than just doing this, because we have to titrate and find the right dose of Clomid for you. So, for example, with women, we'll start them off typically on 1 pill of Clomid, 50 milligrams, 1 pill a day for 5 days. And if that works, great, we leave them on that dose. If it doesn't work, we go up to 100 milligrams or maybe 150 or 200 or even 250. Guys are more sensitive to Clomid, and guys take it every day. So whereas women only take Clomid 5 days out of the month, guys will take Clomid typically every day or maybe every other day. But it's important after you're put on Clomid. So for example, I'll give you an example. My starting dose of Clomid typically is a half a pill a day. So 25 milligrams every day. And what I'll do 3 weeks after starting a guy on Clomid is I'll repeat his FSH, LH, and testosterone. Why will I do that? Because I want to see what the effect has been on those hormones. Because let me give you an example. If I put a guy on 25 milligrams of Clomid every day, and now all of a sudden his testosterone level goes from 150 to 1500, what I have to worry about is now the brain is sensing that really high level of testosterone. And the brain is, instead of responding to Clomid by making more FSH, the brain tells the pituitary gland, hey, you know what? We've got a ton of testosterone around. Don't make FSH, don't make LH, because we don't need any more testosterone. And when FSH production goes down, sperm production goes down also. So it's very important that if you go on Clomid, that we make sure that you're on the right dose of Clomid. Sometimes you might need more, sometimes you might need less. So that's why we evaluate guys from an endocrine perspective. We also look at genetics. Genetics is another common cause of male factor infertility. So what do we do for a genetic evaluation? The first thing we'll do is a karyotype. So we'll look at the chromosomes to make sure that a guy's got 46 chromosomes. We don't want to have an extra X chromosome. We don't want to have an extra Y chromosome. Those things can lead to low sperm counts. We want to make sure those are not factors. We will also do carrier screening. So we have the ability to look at 288 commonly transmitted genetic diseases now. Things like cystic fibrosis can adversely affect sperm function and delivery. We'll look at cilia disorders as well that can adversely affect that. But the other thing that we'll do is we'll look at what's called a Y chromosome microdeletion. So sometimes we have guys who have very low sperm counts, and it's because of a chromosomal abnormality not involving the big parts of their chromosomes, the X or the Y, but just a microscopic deletion of some of the DNA in the Y chromosome. And we know that that can be very, very detrimental to sperm production. We'll also look, for example, if you have no sperm, then the urologist may very well want to do a testicular biopsy, looking at things like Sertoli cell-only syndrome or germ cell aplasia, different issues like that. Again, back to the hormonal issue, we're also going to be looking, I started to talk about this before and got sidetracked, but women go through menopause. There is some evidence that guys go through kind of an andropause as well. So when women stop making eggs, when they run out of eggs, their pituitary gland doesn't want to realize that, so it cranks out more and more and more FSH to try and stimulate the ovaries to respond more aggressively. Same thing happens in guys. So when your testicles start to get smaller as you get older, and they may not function as well, your pituitary gland makes more FSH to try and drive more sperm production. And so if we draw your blood and you've got a sky-high FSH, that tells us what the problem is with your sperm production. And that is that you've got essentially testicular failure. We also look at things like cancer. We look at the medicines that you've taken in the past. And then finally, there's some functional etiologies as well. So things like erectile dysfunction, very, very important. Guys can get erectile dysfunction for a variety of different reasons. Sometimes it's psychological. Most of the time it's not. A lot of the time it's physical. And in fact, it can indicate significant disease. So this may be one way that guys can get diagnosed with diabetes, because we find that they present typically with ejaculatory dysfunction. And in fact, they're determined to have diabetes. Okay, so prerequisites for fertilization. So what has to happen to sperm? When a sperm's ejaculated, does it work automatically? Does it not work automatically? The answer is it doesn't. Sperm have to undergo different processes to enable them to go ahead and be able to work, to swim. When a couple has sex and sperm get deposited in the vagina, first of all, the sperm have to make their way through the cervix, through that cervical mucus into the uterus. So let's say maybe 50 million sperm are put in the vagina with intercourse. Now maybe a few thousand make it up inside the uterus, through the cervix into the uterine cavity. A couple of hundred, if you're lucky, may make it out into the fallopian tube. And they are now swimming down the fallopian tube as the egg is coming from the ovary in the fallopian tube, and sperm and egg meet in the fallopian tube itself. And that's where fertilization usually occurs. And so when fertilization occurs, or for fertilization to occur, sperm that are out there in the fallopian tube during that journey from the vagina through the cervix into the uterus and out into the fallopian tube, those sperm have undergone many different biochemical processes to make them ready to actually fertilize that egg. So they have to undergo a process called capacitation, and then they have to undergo another process called the acrosome reaction. And in that process, the membrane around the head of the sperm compresses, it digests away, and then certain types of proteins on the surface of the sperm head are exposed. And those proteins on the surface of the sperm head interact with corresponding receptors on the surface of the egg, and that lock and key mechanism is what enables fertilization to occur. We know very little about this in 2020. We know a lot more now than we knew 5-10 years ago, but a lot of research is going to focus in the future on identification of that sperm-egg interaction, that lock and key mechanism. And I think we'll be able to see a lot of improvements, maybe potentially even some additives that we can place in a semen specimen to improve the ability of sperm to work. Let's see, we talked about semen analysis in general. We talked about the basic things. So let's go on to male factor therapies. So what do? Well, there's a lot of different things that we can do. One thing that we can do is, like I said, we evaluate the guy's hormones. So if a guy has a low FSH, low LH, low testosterone, we're going to typically put him on Clomid in the hope that we can get his FSH, LH, and testosterone to go up and raise his sperm production. If a guy's got medical conditions like diabetes, things like that, we'll get that treated. If a guy is determined to have retrograde ejaculation or backward ejaculation, it's easy to take care of that problem. What we do is we get the guy to come in, we get him to empty his bladder, we get him to then ejaculate, we get him to take some bicarbonate pills because we want to make sure that we alkalinize the urine, because urine frequently is acidic. We want to alkalinize the urine so that the sperm aren't killed in the process, and then we'll get him to empty his bladder again. And so we may get 100 or 200 cc's of volume, and our andrologists are very adept at processing that urine specimen, spinning it down, isolating the sperm, and then we can then use that sperm very effectively, either for intrauterine insemination or in vitro fertilization. So let's talk about what are the differences between intrauterine insemination and IVF. So intrauterine insemination, or IUI, is a very straightforward, very simple process. And what's involved is when the woman is getting ready to ovulate, we will get the guy to produce a sperm specimen. We get that semen specimen and we evaluate it within an hour of the time it was collected. We wash that semen specimen because we want to take the sperm out of the ejaculate. We know that sperm make up a small fraction of what's in the ejaculate. 95% of the volume of an ejaculate is not sperm. It's enzymes, it's sugars, it's other things that are made by the seminal vesicles, by the prostate, by the tubules that take the sperm from the penis, or from the testicles through the penis and out. And so we will isolate those sperm. We wash the specimen to get rid of the semen. We take the sperm, and then there's a couple of different ways that we can process that sperm. One thing that we can do is called a swim up procedure. And what we do is we take this sperm pellet, we put it at the bottom of a tube of fluid, special fluid. And what happens is that pellet starts to break apart, and the fast moving, typically normal sperm start to swim towards the top of this fluid. And we can then skim those off and use those for IUI or even for in vitro fertilization. This was the primary way that we used to prepare sperm in the laboratory. Nowadays, we use something very different, something called density gradient centrifugation. So what we do is we get the semen specimen. Again, we wash it, we separate the sperm from the semen, we toss the semen, and now we take the sperm and we put them on top of some microscopic beads in a test tube. We put that in a centrifuge, and we spin that down at 400 times gravity for anywhere from 25 to 45 minutes, depending upon the quality of the specimen. So what happens is the fast-moving, normal-shaped, healthy sperm negotiate their way through the beads to the bottom of the tube. The irregular-shaped sperm, the debris, the dead stuff gets hung up in those beads. We toss that. We skim off the good sperm at the bottom. We resuspend that in about, say, 30 to 50 microliters of fluid. And then we can actually go ahead and expand it even more for intrauterine insemination. And Ovation Lab brings us that sperm specimen. We confirm identity with you because that's very important. And I'll talk about that in just a second. And then we put that semen, or that sperm rather, in a very small catheter and guide that catheter during a pelvic exam through the vagina, through the cervix, into the uterine cavity, and deposit the sperm inside the uterine cavity, actually very high in the uterine cavity. It's a painless procedure. It takes 10 seconds. And then we ask the women to lay still for about 10 minutes, read a magazine. We set an alarm. When the alarm goes off, they can go back to work. And there's nothing to it. And what we do is we ask them to not bathe, swim, or douche for 48 hours. We don't want any water in the vagina to wash out the sperm. And then typically, at least for my patients, I ask my couples to have sex after the IUI that day and again the next morning. So that's how we do intrauterine insemination. It's relatively inexpensive. It's typically maybe $380 or so dollars. It's usually covered by insurance, and it's painless. Alternatively, we can do in vitro fertilization. That's a different topic. I'm gonna probably stay away from that tonight because we only have a couple of minutes left. But the IVF process is a way to maximize the use of sperm. Now, as I said before, we like to have at least 20 million sperm per cc of semen. That's what we consider to be a normal semen analysis. And what we'll do is we will isolate that specimen and we will use that. Now, we can, if you've got at least 20 million sperm per mil, you can easily cause a pregnancy in a natural cycle with intercourse. If you've got that number, you can easily cause a pregnancy with intrauterine insemination, and certainly with in vitro fertilization. But what do we do when guys have really, really low sperm counts? Well, the first thing we can do is intrauterine insemination. We like, again, to get at least 5, if not 10 million moving sperm to put into the uterus. And if we don't have that number of sperm, then we do in vitro fertilization. And I can tell you, as unbelievable as this story is going to sound to you, I swear to you it's true. I had a couple who came to see me from out of state. We actually found 5 moving sperm in an ejaculate. And that we did in vitro fertilization with ICSI. We could only inject 5. The woman, I think, made 20 some odd eggs, if I recall correctly. We could only use 5 of those eggs to be injected with sperm. We froze the rest of the eggs, and she had twins. So when guys say, or when couples come to me and they say, oh my gosh, our sperm concentration is too low even for IVF, I say, well, it's actually not, because we've actually had twins with a grand total of 5 moving sperm. So I think we're coming up on the end of the hour here. I want to turn to questions again. Let's see, I got another question here. I recently took a semen analysis and there were no sperm. The past 2 years, I've been diagnosed with low testosterone and was getting 1 cc of injections of sperm biweekly. That's right. And so again, because of what I talked about before, your brain is sensing that you've got a lot of testosterone circulating around. Your brain tells the pituitary gland, cool it, take the month off. We don't need to make FSH. We don't need to make LH, and you don't make sperm. So meanwhile, you say, now I'm off the testosterone for about a month and a half. Is there anything else I should do before I get another semen analysis? No, just stay off the semen, just stay off the testosterone. And it may take, again, 3 to 4 months before we're going to be able to find sperm in the ejaculate. So if you do a semen analysis, like you said, you've been off this testosterone for a month and a half, and you're getting ready to get another semen analysis, it may be too soon. So the first thing I would do if it comes back, again, with no sperm in the ejaculate, I would not freak out. I would just remember to wait a grand total of maybe 108 days or so, 3 to 4 months from the time that you took your last testosterone pill or injection until the time you do a semen analysis. I think that may be it. I don't know if there are any other questions. Brandy, do you see any other questions? I think that is what I have.
Yeah, but looks like that was
terrific. Well, again, I can't thank you all enough. Brandy, I can't thank you enough for helping out with all this. You're such a terrific producer. I really appreciate all your help and all your work and cracking the whip to make us do these webinars, which are really actually a lot of fun. Although I'll admit it's kind of hard to sit here and talk all by yourself for an hour. But I thank you all for taking the time to tune in and enjoy this. If you have any questions, please call us. You can get us on the web at www.txfertility.com. Our phone number at the office, area code 512-451-0149. Again, you can get that on our website. All of the physicians at Texas Fertility know a ton about sperm, a ton about male factor infertility. We would just welcome the opportunity to meet you and have the opportunity to take care of you. So thank you so much again for joining us. I hope you enjoyed it, and we'll see you next time.